Good afternoon, everybody, and welcome to today's webinar, Careers in Internal Medicine. My name is Karen Tucker-Labello. I'm Director of Education for the New York Chapter ACP. Before we begin, I want to review a couple guidelines. All participants will be on mute since we have such a large audience. If you have a question, please type it in the dialog box on the right, and I will read the panelists following the webinar. We also received many questions in advance from the online registration form. These questions will be addressed by Abi Amarani. He's our NYACP Medical Student Council Board rep. I'll be sending the handouts to all participants, and I will have a recorded version online in the recorded webinar section of our website, and the recorded webinar will also be in our medical student and resident page. Our expert panelists today are Dr. Kat Sompel. They'll be facilitating. Dr. Sompel is a gastroenterologist and APD at Brookdale Hospital. Dr. Joe Wayne, Clerkship and APD Director at Albany Medical College. Dr. Michael Accurcio, Physician and Hospitalist for NYU School of Medicine, Langone Medical Center. Chris El-Sayed, Private Practice Physician from NU Family Health Center in Nassau and Counsel for the NYACP. Dr. Mark Bronstein, he's a hematologist from NYU Winthrop. And Abi Bernini, he's our PhD med student, Council Board rep. So I want to welcome all of you today, and we will just start out with Dr. Accurcio.
Hi, everyone, and I want to welcome you to the webinar. Can we see the slide? Karen, can you advance to the, oh, there we go.
I did.
So this slide is just to remind our audience who are here today of how broad the practice of medicine is and what is internal medicine. You know, the American College of Physicians defined it not too long ago, and it's obviously the care of adults, but it's also using the very best available medical science and combining that with thoughtful, patient-centered care. And I think this idea comes from the father of internal medicine, Dr. William Osler. And the next slide. So one thing for everyone to consider is that medicine is so broad, it's almost hard to even start talking about it. When you ask somebody, you know, if they're an internist and they say yes, they might be performing procedures all day. They might be in the laboratory all day doing basic science at a bench, or doing clinical research, or performing primary care, taking care of those in the community. We're leading hospitals, and we're recognizing new diseases and reporting them to different societies and publishing. And if you think about what an internist does day to day, well, it's as varied as there are the number of internists. I don't know two of my colleagues that do the exact same thing every day, and I think that's really, that flexibility is a real strength when considering internal medicine. It may make this webinar more difficult, but it's a real strength in terms of what you want to do. If you go into this field, you can really carve out a niche for yourself.
Exactly. I actually agree as well. I think with internists, I think the beauty of it is that you can kind of make it what you want. So we all start with the same basic foundation, and then everyone can carve out, like you said, a career path that they like. And a lot of times it's not just one thing. People overlap and wear multiple hats. I guess we can go to the next slide now. The beautiful thing also is that, and the great thing about internal medicine is that internal medicine is sort of the umbrella to so many other fields. And as they say, you know, once you become an internist, whether you go into a subspecialty or not, you're still always an internist at heart. And the idea of internists is that they work in specific venues, but then when you go to the next slide, you can see that subspecialists then take a component of what internal medicine is. If we can go to the next slide, that'd be great, the subspecialty slide. And then they take that specific component and they apply their internal medicine knowledge, but then they sort of create a concentration or an area in which they do a fellowship, and then they focus more on that. But as they say, a lot of people never truly are just one field where you can be an outpatient subspecialist like an endocrinologist or rheumatologist, or like myself, a gastroenterologist. But at the end of the day, you're still going to be treating patients from the internist standpoint. And these subspecialties allow you to hone your skills in one specific area while still keeping ties to the others.
Yeah, I'll just echo that as well. One thing that really surprised me when I started my oncology fellowship is how much internal medicine that I was using on a day-to-day basis. And even now as an attending, when I interact with other subspecialties like nephrologists, for example, they are sometimes serving as the patient's internists, and then they're wearing multiple hats, working from the nephrology side as well as the internal medicine side, kind of collaborating on patient care. So I think that's a great point.
I think we can also then go to the next slide. And so one of the things to keep in mind about internists is that internists, because we have a very broad definition, a lot of the other career paths and many of the people on this call also fit this area, is that some of them lead organizations like the CDC or the AMA. Many become deans and chief medical officers of hospitals and members of other organizations like the ACP, and many of them will keep their clinical practice going, but at the same time they'll get involved in advancing medicine, not just from the technical and patient care standpoint, but also from the standpoint of how is medicine an institution in America, and getting it furthered both from the standpoint of being able to help in public health, but also being able to protect physicians and their interests as well. I know that some of us have actually, I don't actually think, oh, yeah, go ahead. I think there's someone on the call who loves to talk about discovery. Am I right?
I mean, I can chime in as sort of an academic physician.
Yeah.
I mean, one of the pleasures of being a physician is being a leader in society, and one of the ways we lead is through discovery. And that can be at a public health level, or that can be at a basic science level, or it can be at various levels where we're really making an impact. So I think when you're thinking about a career, you want to figure out where you want to go above and beyond to change medicine, and that can be on the front lines in the community. That can be in a foreign country practicing in a indigenous area, or that can be on a bench on a laboratory. And I think discovery is at the heart of what sort of drives medicine.
Yeah, that's a great point. And I think a lot of people go into various careers and various avenues of medicine.
I just wanted to make a point about the in academic centers. It's very often the Department of Medicine. In some schools, that might be the Department of Internal Medicine. That dominates in terms of the total number of grants to fund both clinical research, full thickness programs that really drive the academic center. And if you were to compare it to other departments, it's really where all the action is. So internists really lead in many ways, and I think that they lead in terms of the science as well.
Before we move on from this slide, I think it would be really wonderful to hear from each of you. We see here the academic career, the private practice, administrative work, hospitalist, subspecialty training. I highly doubt that any of you do all of these in the same week. So it'd be really interesting to hear as students sort of how you divide your time, let's say within a 1 month, 2 month period. And then also hear from each of you how your career trajectory began once you finished your internal medicine training, and how you reached where you are now in your careers.
Sure, I'll go. This is Mike Licurcio. So I finished residency from a categorical program nearly 20 years ago and joined an inner city clinic doing primary care for an underserved population. It was there for the next 8 years that I worked, thrived, and really noticed that what put a big smile on my face every day, besides my patients, was the students and the residents in education. And so from there, I really started focusing much more on medical student education and curriculum. About a little over 10 years ago, I decided to switch to become a hospitalist. So I went into that same inner city hospital and serving the same population, sicker patients were hospitalized, and began teaching on inpatient medical teams. From there, I had actually more flexibility in my time to be able to work around my patient care sessions. And that's when I became clerkship director for the medicine clerkship. Today, I work in a few weeks at a time doing inpatient work with the medical team, and I spend pretty much every day just making sure that the students are all right and their multiple scheduled academic sessions per day.
It's a very cool timeline. One of the things in my career, this is Niket, was it actually began with the ACP because so I had done a poster when I was a medical student, and through that poster and through my time with the American College, I was able to meet my future program director at one of these sort of events, which was actually a residency fair held at that time it was at NYU, and that kind of catapulted me into medical residency. And during that time, I went into fellowship, and then during residency and fellowship, I met a board review educator who is a program director here at Brookdale. And after I finished my fellowship, rather than going into private practice or just pure like GI hospitalist, I realized that I missed the teaching of residents and working with medical students, and just sort of putting things in and out of people all day long wasn't as exciting as I thought it was going to be. So I took a job as an APD here at Brookdale, and the reason why I tell that story is because so many different times when you think you know exactly what you're going to do and which way your career is going to go, how you feel from one day to the next changes a lot, and that impacts a lot of how you're going to go into work, and then that's going to impact the field and the direction your career goes.
That's such a great point, Niket. This is Chris Elsiad. I always thought I would see myself in a private practice office and doing primary care there and tending to the ill there, but medicine is a dynamic field. Just like we come up with new medications and new guidelines and new testing, the same goes true for the business world. And I was in private practice for over 10 years, and things kind of change, et cetera. I always had a hand in the hospital and started doing primary care for the hospital, and they needed help with the resident clinic, half the time. So I jumped in doing that, and the students came aboard, and it kind of shifted your gears a little bit, and I absolutely love what I do, working with the medical students and the residents and doing primary care directly with the patients as well. So.
This is Mark. It's always inspiring to hear the stories of how people's career trajectory takes hold. Personally, I'm someone who has a hard time settling down onto one subject because I find myself just interested in everything. But ironically, I ended up subspecializing in hematology oncology because I found myself most drawn to that, most excited when I was reading, and most fascinated by the research aspects. And I definitely have not regretted that decision. My time is mostly divided now as an attending, seeing patients mostly in the outpatient setting about 3 days a week. And the other 2 days are either administrative or research days, or I'm also involved with the building of our medical school here, which is something I hadn't anticipated doing when I started on this path. So. And then I'm also on service about once every other month for a week. So it's a good sort of dynamic range of responsibilities. And I've carved that out based on my interest. I don't think there are any limitations placed on me. So definitely you can take whichever kind of path that interests you and build it the way you like.
Just out of curiosity, are doing something today that they didn't think they were going to be doing when they, let's say, graduated medical school?
And clearly, I never thought of myself, this is Joe, as an academic administrator, and that I would ever want to be interested in or study how to assess learners and trainees. It has nothing to do with clinical medicine, but has everything to do with it to make sure that they basically have all the skills and we get the right feedback on them. But this has kind of been my work at this point as to how do I assess that people are becoming a good doctor. I never would have thought I'd be there. It's completely different than what I do in the office with my clinical patients. And it's truly an academic exercise in going through all this evaluation of students and residents. And it's the interesting stuff, and this is what I find interesting now, and it keeps me going.
Anyone else?
No,
I mean,
thank you all for sharing all of that as we move forward, and then we'll do more questions I think throughout. But it seems like we have a few more slides that sort of specifically highlight the different training options and highlight the trajectory in this flow chart here.
So the thing about academic medicine and the term academic medicine, it is also broad, but it classically involves working specifically with either trainees or patient care with research or patient care with research teaching, but it's more than sort of just day-to-day clinical. It's passing on your skills, your knowledge, your viewpoints, both the science of medicine as well as the art of medicine, and giving that to both motivate and train future trainees. And a lot of people like to have even a small component of academic medicine, whereas, for example, many private practitioners still do a little bit of teaching, attending service, and so forth, because we were all trained in that modality, and so I think that instills in us a desire to want to do that in the future.
Yeah, I agree. I mean, I think that even the concept of an academic clinician is changing because there are now sort of academic private practices that can do, groundbreaking clinical research and publish national trials and be the primary investigator for a trial, yet not necessarily affiliated with a major academic institution. But this classification is primarily based on the premise of a sort of academic hospital-based physician, and so at some point you will be looking and settle on a job, and it's sort of thrilling and it's exciting, but at that point you have to appreciate the fact that time is a limited resource, and your employer is going to appreciate this. And in that sense, they're going to put certain expectations into your practice, and that's going to be based on how much time you're either seeing a patient or how much time you're doing research or other activities, and you may have to meet certain milestones there. So time is going to be a limited resource. And in that vein, you have to kind of decide what kind of clinician are you in the academic setting. Are you a clinician educator who is primarily building curriculum, teaching residents, students, or fellows? And that can involve publishing and research as well, but it's more from a didactic teaching point of view. And then there's the physician investigator, which is typically somebody who's doing sort of prospective research or clinical research, and that can be in the form of a clinical trial, or it can be the form of public health research. And then there's the physician scientist, who I think traditionally is someone who's considered to be someone who goes from bench to bedside and back, someone who's practicing, maybe seeing patients as well and wears multiple hats and also has a laboratory and postdocs running a laboratory. But I think that concept of physician scientist is someone who spends more of their time than, say, a clinician educator doing some form of major research.
So we're jumping into a different sort of realm. This is kind of one of the things that you're going to be expected to produce. They have categories of productivity and how it will affect your bottom line. As they say, when you go to find your employment, your job, your employer usually will have X amount as a base, and also there will be some discussion of productivity. Depending on what part of the field you're in, the productivity can vary greatly. If you are expected to teach more than see patients directly, then there is a higher push towards teaching and quality and mentoring. And if you have different things like you are more patients in addition to just taking care of the students and the residents, then there may be a number or RVU-based system. So it's all very variable and very dependent on what field you're going into, but this is something certainly to keep in mind, because as young residents, when we went out and looked for employment, productivity is not always something that we ever thought of and what we have to produce to finalize our situation.
When I think of research, I think of it as an investment, and with any investment comes benefits and also comes risk. So with the benefit of research is obviously it allows you to develop an area of expertise that you can own and you can be familiar, you can be associated with. You can be the lymphoma specialist or the diabetes specialist in your field. And it can be exciting, and you can really make good contacts and travel and give talks, and it's really thrilling to achieve that level of success in research. And in that sense, it also helps with career advancement. But there can be significant challenges. It requires a lot of time, and there's no guarantee of success, but there are ways to at least assure that you are going on the right track. And I'll talk about that in just a second. The other thing is that it may require funding and protected time. And, you may have protected time built into your contract, but it's important to kind of know that in advance when you're looking for a job or even when you're going into a subspecialty fellowship, how much protected time you may have during your training to really invest and free yourself from other responsibilities that are going to take away from the research. So I would say the number one key to success in any field is really mentorship. Someone who's kind of gone through the trials and tribulations of the process and have gone through the pitfalls and kind of has the confidence and the track record to really ensure your success. And so starting early is important. If you're interested in research in your internship, or your residency, start as early as possible so that you can try to overcome any pitfalls that come up. And try to develop with your mentor a thorough research plan that includes how you're going to address potential pitfalls. Even if you're doing a simple chart review, what are you going to do if you don't have enough subjects, or how are you going to get the biostatistical input as early as possible? So those are things, that are important to discuss with the mentor. And then as you think about a research project, you want to kind of decide what interests you. Do you want to, and what is the question and hypothesis that you're testing? Do you want to do a retrospective chart review or a prospective interventional study? Do you want to do public health research or something like practice improvement? Like, can we decrease the time that the patient gets discharged to seeing their primary doctor, things of that nature? So most fellowship programs will allow for some dedicated time. I find more so than in residency, but sometimes they'll offer like a research kind of like fellowship or almost, where they'll offer more time during your residency to devote to research, like usually a month or two. And then the last thing is it's never too late. You can be an attending, you can be a senior attending. It's never too late, really, to get into research. And what's really interesting is that you may start at one point and then find yourself led into a completely different direction based on a conversation you had at a seminar or a thought you had at the bedside, something we do every day, and how come no one thought to do research and fix this? ideas may come as you progress in your career.
So after being in private practice for a long time, and residents they graduate and they decide, geez, what kind of office setting do I want to work with? How big of the group is it going to be? A single office? Is it going to be a multi, 100-doctor group, multiple 100-doctor group? That I want to be a part of. What kind of patients, and do you want to get involved with students or residents at all? Some of the physicians I worked with were very happy being in their silos. They didn't want any more, action or having to teach anybody or any of that. They just wanted them, the patients, and go home. So if you fall under that subtype, that's fine. If you don't, and you want some more exposure to residents and students, keep that in mind. And the final point, which is very important that we are seeing now, a lot of the residents and fellows graduating, they speak with me about they're thinking of this. Where is the practice going? A lot of the small practices now are all joining with big hospitals or big groups. And as the lowest member of the totem pole, as an associate, where does that lead to? So that's very important to think about in your future endeavor.
So I think here, yes, Lip? Oh, I was just going to say that I think here what primarily is being sort of outlined is you can only make the decision of what kind of medicine do you want to practice. Do you want to be a part of a large hospital system, something medium where it's a group faculty practice that may or may not be affiliated to a hospital, or something small where you're an individual solo practitioner, a concierge medicine person, or even a locum for that matter. And that's a decision you'll know as time goes on. Location is key. A lot of people will know this, and it would be interesting to see, what are some factors that go into it, but I think it's a very individual choice, whether you want to be in a big city or whether you want to be, for sort of like the old school, one dock in a town somewhere in some part of the country that's underserved. And then, as we talked about before, patient populations vary greatly, and the catchment areas of hospitals are also very varied. And in internal medicine, one of the great things about it is that you can have an opportunity to see patients from all aspects of life, all cultures of life, and ranging from very, very underserved, low socioeconomic status areas where certain diseases are more prevalent to different populations, as can just sort of be seen by the diagram here. And now pay is an area that Dr. Curcio put a good slide together to say that no matter what field you choose, don't choose your field based on the bottom line. Many of you will get like the Medscape emails that say, who makes the most money this year? At the end of the day, what really matters is that having a great career is rewarding in and of itself, and each and every one of you, regardless of whether you're in internal medicine and you're in family practice, or if you're internal medicine and you're thinking of pediatrics, or you stay in internal medicine and you pick one of the different venues, whether it's subspecialty or whatever it is, everyone does well. But we always, I think, wholeheartedly, we all tell you not to pick based on just numbers alone.
One thing to add, I'm just advising residents and students all the time. I have seen so many people make the wrong turn and do things for the wrong reason. And in the end, it's never too late. They do come back. They do come back and do what makes them happy. But I can't tell you how important it is to like your colleagues. The people that you're in the trenches with day in and day out, and that might be a small practice with one other person, or a very large one where you have to cover each other and just your work life. It's going to be a large part of who you are as a physician, and liking the mission, having a shared common goal, and liking each other, I say, would be the two most important things.
That's a great point. Absolutely. this is a very good point. I think Dr. El-Sayed, you wanted to speak to this.
Sure. It's your strongest ally. I mean, the program director is fantastic, and they helped you your whole residency career and everything. But your strongest ally may not necessarily be when you're looking for a job, the program director. It could be the mentor faculty that you had. If you also get it out that you want to stay in the area, and you kind of get it out, and the staff likes you, you never know. I was just discussing with the crew that my job in private practice I got because one of the ICU nurses was friends with a receptionist in the local big practice who just, one of the doctors passed away and they were looking for a doctor, and the things kind of meshed, in a way, and stars aligned, as they say, and it worked out. But a lot of the residents will come and discuss with me, who consider me a mentor, and what do you think about this job? Should, this and that. So it may not necessarily be the program director. Find whoever you feel comfortable with, and they will certainly help you as much as they can.
So to give you guys some extra resources, there's a list here of various places you can find job listings. Obviously, the ACP itself is one of the best. The New England Journal of Medicine also has job listings. Any of the conferences you also go to will have dedicated specific workshops and also ways for you to meet employers. And so that's one of the strengths of being an ACP member as well, is that if you're looking for a job, someone knows somebody. Just to give you guys an idea, there's going to be some additional info on a different type of fellowship for those of you who are interested more on the institutional and business side of medicine. It'll be included in the PDF and packet that goes out.
Oh, I want us to, I put this slide in just to mention one of the fastest growing fields in all of medicine right now is the hospitalist. This is a very varied role. And in fact, it's usually defined as anyone who spends most of their time working in the hospital. And so this could include subspecialists who are doing consultative medicine or working in the intensive care unit. But the most common one now is the general internist. And about 20 years ago, hospitals began to recognize that, well, they really couldn't run the hospital the way they used to with residency work hour restrictions. And when they had more senior people working in the hospital, they realized how much better the patient care can be. And I'm a hospitalist. I spend most of my time taking care of those who are admitted to a general medicine ward. And it's very fun. In a lot of ways, it's what you're training for during residency training. But it's also where the students are, where the residents are. I can't tell you how many people I've worked with who use this position just for the first 2 or 3 years of their career while they're looking for that correct fellowship, or they use it just to try out different things or to solidify the information the training that they've had as hospitalists. Some people move on to fellowship, but those who stay, it's not too long before they're running the whole of hospitalists, and this is also the group that tends to now be looked at when they're looking for chief medical officers in most hospitals. So it's a fun, exciting field. It's diverse, and it's probably as varied as there are hospitals, but I'm happy to expand upon this during the question session, if there are any questions about it.
Subspecialty training is also, as we mentioned earlier, it's an option for many of you guys to take, and there's so many variations of subspecialties, and even within the subspecialties, there are subspecialties like, for example, I'm trained in gastroenterology, but then I have a focus specifically on inflammatory bowel and liver disease, and so there are other ways to also enhance your skill set and hone certain skills, and there's so many different variations of it, and some people combine them. Like I have a friend who I did residency with who did critical care and cardiology because he wanted to be the director of CCU at a big center somewhere, so he specifically tailored his training that way. And so there are various different ones, and various different ones have very timeless. And so here's just a listing of different steps, but it's very similar to the flow diagram that we had earlier. So we can go to the next slide.
Hi, I'm just going to interject for a second. We got a question. Dr. Licurcio, can you run through a daily or weekly work schedule of a hospitalist?
Sure. Understanding that, of course, it's very different in different hospitals. So when I am working as a hospitalist, I will basically be working with a resident for 4 weeks. And we get to know each other very well because I have a very much like my training methodology is very much to train the next person to do my job. So I really set up a system where the senior resident in particular would run the service as an attending. And I'm more there as a colleague, working through the tougher cases, helping them think through the case, helping them through the day in terms of the teaching sessions. So a typical day for me would be going the team for work rounds early in the morning. Then I would probably peel off after seeing all the new patients and anyone else that I thought might be having a difficult time. Then I would head over to multidisciplinary rounds with a group of nurse managers and social workers to talk about some of the discharge issues or some of the nursing-related issues for each patient on the ward. After, I would spend the next 2 hours with the medical team reviewing new cases or tough cases. And here's where I really focus on the academics of medicine, discussing the differential diagnosis, what in the history is, what do we need to know in order to make the diagnosis, and what's the next test. The afternoons is really a time where I catch up with my administrative work for the clerkships, write all my clinical notes, and then really just become a resource for that resident and medical student team. But the key there is to really empower the team to be the caregivers.
So we are on the last subspecialty training slide, Dr. I don't know, I kind of interrupted there for that question because it was regarding the hospitalist. So I don't know if there's anything else you wanted to elaborate on, because our next slide goes right into questions again. And I know Abhi has a few that he would like to share with us for online registration. Good. So Abhi.
So if we go on with questions, then one of the questions that came in was specifically from a student who was interested in public health, law, and clinical trial drug regulation type issues. And so the question was focused on, well, one, how can like residency and internist and hospital practice benefit from students or residents taking roles in, you know, better understanding public health law, clinical trial, drug regulation settings, and then also sort of what career trajectory would potentially that entail for an internist trained resident.
Well, I can start the conversation because one of my colleagues in my fellowship was actually a policy fellow through the American Society of Clinical Oncology, and his role was to actually lobby with Congress for certain elements of MACRA and the revision of healthcare reimbursement that's currently ongoing. As it relates to oncology, because oncology medications obviously take a big slice of the healthcare pie in terms of finances. So I think this is definitely the time where we need advocates who are physicians to work with our leaders in Congress and work from a public health point of view to advocate for the things we need, and that includes clinical trial drug regulation. There's obviously a lot going on in terms of healthcare policy and law, and it's up to us as internists to advocate for our field and the changes we need. So I think the career trajectory would probably be working with professional organizations like ACP to kind of channel our needs and the kinds of dilemmas we deal with from a global perspective day to day in practice, and really channel that information to policymakers so that it can positively impact our field.
Okay, thank you for that. So it sounds like for students and residents who want to work on policy and law and really play a larger advocacy role, our professional organizations are really ones to look for in terms of perhaps becoming a policy fellow and taking dedicated time off. And I guess also probably the residency director at their institution, I would imagine, would also be a great person to speak with in terms of who to communicate with for mentorship on that.
And Abby, I wanted to point.
Yeah.
I was hoping one other resource. I believe that the American College of Physicians has an advocacy fellowship for medical students and residents that's offered in the summer. And I think that's available on the ACP site. And if I'm not mistaken, Linda Lambert just did a recent webinar on medical student advocacy.
Actually, refer to our advocacy internship at the NYACP in our office. Is in the spring. We take six to 8 residents or med students for a 1-month rotation to work with my executive director, Linda Lambert. And I believe it's kind of accredited through Albany Medical College. I'm not sure of all the technicalities of it, but yeah, it's in the spring. We I think med students and 3 residents this year. Very popular program. So if anybody's interested, they can just jump onto our nyacp.org website. It's even on the resident and med.
And in just a second, that it is a well received by the students. Excuse me, and just making sure that when they apply from different institutions that they actually have a similar course offering at their home institution that would qualify them for credit for taking the elective.
That's a wonderful series of resources for students. Thank you for that, everyone. And so changing gears to a second, as medical students, often our scores, our grades really press a really big role as we are trying to figure out where we would go for residency. I wanted to know where scores and grades matter in terms of, for example, fellowship versus private practice versus being a hospitalist versus research roles and career trajectories after residency. And besides scores and grades, what else can matter and play an important role depending on what path we go into?
I guess I can start out again since I was applying to fellowship not too long ago. But I mean, I think when you're a medical student, grades and competition are so much more omnipresent because there are limited residency spots. But I can tell you from experience, over time, as you build your career, grades and evaluations become less critical. And what's more important is your communication skills, your collegial skills, how amicable you are in the program. And from one point of view, you're always on a job interview day to day when your colleagues see how you interact and how collaborative you are. So while I think grades and board scores and all of that definitely go into the metric to rank students for residency and perhaps to a lesser degree, but somewhat in fellowship. I think your program director, as we mentioned, and your letters of recommendation start to weigh much more heavily as you progress through your career, because the people hiring you want to know what kind of character you have and how much of a colleague you're going to be, because as we discussed earlier, it impacts their work life, and they have to rely on you to manage their patients, and they want to know, is this someone I'm comfortable taking care of my family or my patients? So I think those things become less important over time in terms of grades, and what's more important is your character and your clinical acumen and how you present yourself.
Exactly.
Yes.
I agree with all that. It's also how much interest you display in that field, the research and being a part of that field. Even though it's during residency, you're focused on residency, it does look favorable if you're involved in, say, for example, research, you attend the meetings, you submit abstracts, pictures. It is to show that you have an interest in the field, and that helps get you a little bit of a leg up. But I do know that in some programs, especially with some of the more competitive fellowships, they do use the USMLEs as a way of weeding people a little bit when they get a lot of applications. So it's not that it's 100. I wouldn't say it's totally off, but it's definitely one smaller component.
Okay. Thank you, everybody, for clarifying that. In terms of the other questions, we had one question that asked about important factors for residency applications for internal medicine. What I'll do here is I'll forego us discussing that and let the audience know that we have another webinar specifically focused on applications, residency application to internal medicine specifically, and ask people to look at that. Karen, were there any other questions that were posted from the people that are on now?
No, we have a bunch of shy ones today, Nick, so we don't have any more in the queue. And that's almost wraps it up anyways. We've been almost an hour.
Yeah. So Karen, if we can, before we close up, I'll ask each person here if they could give one line of sage advice to themselves when they were, say, in their PGY 2 year of internal medicine. What word of advice would they give to themselves? And then maybe we can close out.
That's great. Okay. Let's start with Niket. What do you have to say?
I would say that, be true to what you want to do. And one thing that I think I've learned is if you can do your fellowship somewhere different than where you did your residency, it's actually, it gives you a better taste of what medicine is like everywhere. And you actually grow from that. I did my residency in the same place, and in hindsight, I think I would have been better off somewhere else.
Great. Dr. Wayne?
I would say don't be afraid to say you don't know something. As a supervising resident, you don't want to just blindly go and do things because you think you know. If you go, I really don't know about that, don't be afraid to ask for help. It's not a sign of weakness. It's actually one of the things program directors look for. And it's a valuable attribute to have, to say, I'm at my limit, I need some help.
Dr. Licurcio?
Be true to yourself and take note at what makes you smile. I think those are the two most important things. If you find yourself reading more in one area, or just finding one field fantastic, or why am I spending all my late evenings teaching the students, take note of it. Sometimes it's so obvious what you're enjoying, because there's so many avenues in internal medicine that if you just notice what makes you jump out of bed in the morning, you're going to have a great career.
Good advice. Dr. El-Sayed?
Work hard, obviously, keep working hard, and don't force it. If you want to just gunning for a certain fellowship or a certain part of internal medicine, things will work out. Things happen for a reason. It's just a cliched thing, but it really is true.
Dr. Bronstein?
I'm the son of a lawyer, and one of my father's favorite quotes from one of his law professors was never to drop your briefcase and run. So I think you have to keep hope. I mean, there are always going to be hard days when you feel like you don't know anything, or you don't know as much as your colleagues, or you really need to read more. But I think you have to kind of keep focused on what your goal is, and try to enjoy the process. I feel like I'll never have that degree of control over what was going on in the hospital that I had in my PGY 2 year. as grueling as it was. So when you can, try to take a moment and just enjoy the process and give yourself sort of the confidence to know that you really are acquiring the skills that will take you farther in your career.
And Avi.
Oh, well, I haven't gone through residency yet.
You can just give some.
Yeah. A phrase that I like to always tell, and I think to med students who are applying to med school, and I think the same thing applies, I guess, for us as us med students apply to residency, is that even if we think we're interested in something, whether it's the policy side or the research side or the medical education side or anything else that we would do after internal medicine, I think it's essential to always test our interest as best we can. And I think that's something that maybe we'll keep doing. So just testing our interests as we move forward and sort of pushing the barriers of what we think that we can do.
I'll say my 2 cents from the chapter and from ACP. We have a lot of resources for residents and med students. We, hope you can tap into from our poster and abstract competitions, Doctor's Dilemma, career advice webinars. It's all on our website, nyacp.org. I'm the liaison for both committees, so please feel free to contact our office anytime. I'd love to thank our panelists today, Dr. Stampel, Dr. Wayne, Dr. El-Sayed, Dr. Bronstein, Dr. Licurcio, Avi. This has been one of the best webinars we've had. Very informative, very enlightening. I think you gave all our attendees a wonderful overview of the different areas of internal medicine. I mentioned at the beginning, we will be hosting this on site as a recorded webinar on both the resident and student page. I'll try to get that up tomorrow for you guys. And so it'll be a reference tool for your IMIG clubs. I'll send the handouts to anybody who wants it. And if anybody has any additional questions, send them to me and I'll be happy to respond to my valued panelists. So once again, everybody have a wonderful night. I've taken up an hour of your time. And thank you so much again to our panelists here. Good night.
Thank you.
Thank you, Karen.
Thank you. Good night.
Good night, everybody.